We are live.
Good evening, everyone. I'm very happy to welcome you all for this month's case presentations. As you all know, we are celebrating Glaucoma Awareness Week this month. So today we'll be discussing cases on glaucoma. In January, we discussed cases on cornea. In February, we discussed cases on uvea. And this month, we are discussing cases on glaucoma. So it's my honor to introduce you all to our Chairman Scientific Committee, that is Dr. Piyush Bansal. So sorry. Yeah. So is my slide visible? Hello?
Yes, ma'am.
Okay. It's my honor to introduce you all to Dr. Piyush Bansal. Actually, he doesn't need any introduction, but he's the Chairman Scientific Committee of Maharashtra Ophthalmological Society, and he did his MBBS and MS, and then he did his FRCS, FICO, FACS also, and he's the founder and director of Bansal Vision Institute at Pune, Maharashtra, and he's consultant ophthalmologist and vitreoretinal surgeon at D.Y. Patil Medical College, Pune, Jahangir Hospital, and Aditya Birla Memorial Hospital, Pune. Then he's also the member of scientific committee at the All India Ophthalmological Society. He's the executive member in the governing council of the Vitreoretina Society of India, and he's credited with delivering over 350 faculty lectures, and he has more than 50 peer-reviewed index international and national publications. And his areas of interest are macular surgeries, diabetic vitrectomies, AMD, retinal imaging, etc. So it's a great honor to introduce Dr. Piyush Bansal. So over to you, Dr. Piyush.
Thank you very much, Dr. Archana Vare, madam. So I'm sure everybody knows her. She's been spearheading this case presentation by postgraduate students for the Maharashtra Ophthalmic Society. She herself is professor and head of department at Government Medical College in Aurangabad in Chhatrapati Sambhaji Nagar. And apart from this, she's also the member of the scientific committee of MOS. And I thank madam for the kind introduction. So with this, we'll move on to introducing our expert faculty for today. Before that, so we also, before going on to the faculty, we also have two lovely final year residents, Dr. Tanvi Ajmera and Dr. Harshnoti Purve from Mumbai and from Gondia respectively. And Tanvi is being mentored by Dr. Omkar Telang in KJ Somaiya Medical College. And in this particular case presentation, she's being mentored by our own Dr. Preeti Kamdar, who's an honorary consultant there at KJ Somaiya, apart from being an exceptional private practitioner in Mumbai, and also the Joint Secretary of Maharashtra Ophthalmic Society. And Dr. Harshnoti is being mentored by Dr. Praveen Dhuwadapare, who's an assistant professor in GMC in Gondia. So we look forward to your presentations. We would like to thank both our expert faculty, who I'll be introducing, the first being Dr. Parul Ichpujani. Of course, we all know her. She's a professor in the Department of Ophthalmology in Government Medical College and Hospital in Chandigarh, with her areas of interest being in visual function, glaucoma imaging, neurodiagnostic smart apps, and practical AI. Now, she has a lot of achievements, which she's not mentioned most of them over here, but some of them being that she's amongst the top 40 ophthalmologists from all over the world under the age of 40. So essentially, she's in the power list of, she was in the power list of 2015, which continues still. She has received various honor awards for contributions in ophthalmology, including the one given to her by MIOM, that is the Middle East Ophthalmological Society, in 2024. She's a member of the Education Committee of World Glaucoma Association and has received Young Ophthalmology Teachers Gold Medal with the Federation of Ophthalmology Teachers in 2025. She's editor and author of several books and has, oh my God, 115 PubMed indexed articles. So we thank Dr. Parul Ichpujani, who's a very dear senior colleague and friend, to be over here. We also have our own Dr. Ajit Hazari, sir, who's from Chhatrapati Sambhaji Nagar. He's the chief consultant at Hazari Eye Hospital, and he's essentially a glaucoma, phaco, and refractive surgeon. Having completed his MBBS, he did his DNB from KM Hospital, Mumbai, and a long-term fellowship from LB Prasad Eye Institute, primarily focusing on anterior segment and glaucoma. So he is an avid follower of Art of Living, my senior colleague from LB Prasad. And thank you, sir, for being here and guiding our postgraduate students. So with this, we can perhaps move on to the case presentations where Madam can, Dr. Archana can explain the process. It's essentially going to be a presentation with the question and answer sessions, half an hour each for both cases. So over to you, Bare, Madam.
We have two presentations today. So Dr. Tanvi Ajmera, she is a junior resident 3 at KJ Somaiya Medical College, Mumbai, and her mentor is Dr. Preeti Kamdar. And she is honorary glaucoma consultant at KJ Somaiya Medical College and Research Center, Mumbai. So she'll present her case, and the experts will be asking her questions, and most of them should be the exam-oriented questions. So over to you, Tanvi. You can start your screen share.
Good evening to one and all present here. I am Dr. Tanvi Ajmera, Junior Resident 3, going to present a case on chronic aqueous misdirection under the guidance of Dr. Preeti Kamdar ma'am, Professor in KJ Somaiya Medical College. A 55-year-old female resident of Mumbai was referred to us for further management, presented with diminution of vision in the left eye since few months. Her ocular past history, as per records, presented that in 2016, the patient underwent left eye cataract surgery with trabeculectomy. The surgery was uneventful. Further on, the patient followed in 2023 May, where the patient had diminution of vision in the right eye, and the fundus finding showed right eye optic atrophy and left eye within normal limits. In 2023 October, patient further followed up with the pressure of 30 mmHg in both eye, and the patient was started on anti-glaucoma drugs. The fundus finding noted was CDR is 0.9:1 and CDR in the left eye 0.8:1. Then in November 2023, the patient was advised right eye YAC PCtomy, and again in the December 2023, patient followed up where the pressure were within normal limits, and the patient was continued on the anti-glaucoma drugs. Again in 2024, patient presented with the pressure of 24 in the right eye and the left eye 30, and the patient was continued on the same anti-glaucoma drugs. Patient had lost to follow up, and the patient again came in 2025 February and presented with the pressure of right eye 54 and left eye 60, and was referred to us for further tube or shunt surgery. OCT and VFA were not done. Then in ocular examination, in the right eye, the vision was PL positive, PR inaccurate, and in left eye, it was 6/120. Near vision was less than J7. Then in the ocular examination, we found that the both eyes, the anterior chamber was shallow, both centrally and peripherally, with peripheral iridectomy patent. In the right eye, the pressure was 50 mmHg, and in the left eye, the pressure was 44 mmHg. Gonioscopy was done where it indicated 360-degree angle closure. Initial assessment, and we can see this, that the anterior chamber is shallow both centrally as well as peripherally, along with peripheral iridectomy present, which was patent. In the fundus examination, we saw glaucomatous optic atrophy in both eyes. And we performed VFA for this patient, which showed left eye tubular vision, which was confirmed by performing 10-2. Provisional diagnosis. Based on the clinical findings, the patient was diagnosed with both eyes chronic aqueous misdirection syndrome with uncontrolled glaucoma with glaucomatous optic atrophy with only tubular vision in the left eye. On treatment, we started the patient on Diamox 250 mg 3 times a day. Both eyes, travoprost eye drop once at night. Fixed drug combination of brimonidine, brinzolamide, and timolol was given 2 times a day, and atropine was started for 3 times a day. She was counseled for further surgery. After 1 week, the patient was followed up and the patient improved symptomatically. The IOP was 26 in the right eye and 12 in the left eye. Anterior chamber was deep and quiet. Iris and IOL diaphragm moved back with deepening of the anterior chamber. This is the effect on the anterior chamber pre-treatment and the post-treatment. My differential diagnosis for this cases is suprachoroidal hemorrhage, pupillary block, and serous choroidal effusion. Discussion. Aqueous misdirection is a challenging form of the secondary angle closure, which presented with elevated intraocular pressure, shallowing of the central and peripheral anterior chamber, despite of the presence of patent peripheral iridotomy. Pathophysiology, it is based on the valve-based mechanism. Breakdown of the blood aqueous barrier intra or post-operatively leads to loss of normal osmotic forces in the choroidal vessels, which leads to choroidal volume expansion. There is an increase in the aqueous outflow along the pressure gradient, and which leads to anterior displacement of iris and the lens diaphragm. The clinically, patient will have 4 clinical distinct features, which shows shallow anterior chamber, both centrally as well as peripherally. There is patent peripheral iridectomy, anterior displacement of the lens iris diaphragm, and mostly it is associated with increased intraocular pressure. Medical management, we will start the patient on cycloplegics, aqueous suppressants, and hyperosmotics. If they fail, then surgically we will manage by Nd:YAG plus anterior hyalodotomy or vitrectomy with iridozonulohyaloidectomy. Patient was advised to continue on the cycloplegic for the longer interval of time, and risk of fellow developing aqueous misdirection is significantly high, and we should treat this patient prophylactically with aqueous suppressions and peripheral iridectomy. Thank you.
Dr. Tanvi, that was a good presentation, but as a PG examiner, I must tell you a few things before I go to the experts. First thing is you have to follow a certain protocol when you present a case in your MS exams. Like skipped the negative history and all the other histories. You cannot skip the histories. And in ocular examination also, you have to start with head posture, facial symmetry, ocular position, and ocular movements. Okay, so you should not break that protocol. You have to go according to the protocol. In the diagnosis also, you have missed pseudophakia in both the eyes. Okay. So with that, I'll go to the experts, and I'll go to Dr. Parul first. And ma'am, will you please ask some questions to Dr. Tanvi?
Hi, Tanvi. Data, you have not described gonioscopy anywhere in your findings. And why did you label it as chronic misdirection and not as acute misdirection?
Ma'am, because the patient had presented chronically with the increased intraocular pressure. Past history also, the patient had increased intraocular pressure. So,
a few years after the surgery, the pressures were relatively in the normal range. It was only at one chance finding that they were in 50s. Prior to that, there was no record of that high a pressure. So was any imaging done, an ultrasound or UBM done?
Ma'am, no, ma'am. Ultrasound, we had not performed the ultrasound at that point of time because we were not able to perform that time. But we started the patient on the cycloplegic drugs, and which it improved vision, which showed that the shallowing of the AC was improved both centrally and peripherally, and the AC had deepened quietly, which was suggestive that our diagnosis is most probably correct of clinically correct, pointing towards the aqueous misdirection.
So was this patient a known case of primary angle closure glaucoma or primary open angle glaucoma?
Actually, when the patient presented to us, we had these much records which were provided where they never mentioned any history of angle closure or open angle glaucoma. The patient, when the patient presented, she had already the pressure of 54 and 60. And that time the patient had presented to us. So previous histories, we didn't know that the patient had angle closure glaucoma or not.
So did you have access to any of her past records? If her biometry sheet prior to the phacoemulsification was available, then you would have, okay, I'm just saying, if it was available, then you could have gotten an idea about her axial length and of her
Yes,
hyperopic.
ma'am.
So
Correct.
usually patients with primary angle closure glaucoma, despite having a phacoemulsification, are the ones who are more prone to develop a chronic aqueous misdirection, especially hyperopes, elderlies, females, and those who have been on miotics. These are the special subset of patients who are prone. So whenever we write a discharge card for anybody who has had undergone a surgery like that, then we must document all these findings so that wherever they carry their records, any other person also is able to ascertain the past history relevant to this case. Second, the gonioscopy has to be done. As a resident, you have to draw a Becker's
Gonioscopy
goniogram.
was done.
Um,
Gonioscopy was done. It was closed. I think she mentioned it in her
I'm sorry, I asked.
examination paper.
My
Yeah,
bad.
it was done.
Yeah,
Great.
so as a resident, you must document it in the form of a Becker's goniogram so that when you're giving your exam, the documentation is complete. Additionally, an imaging in the form of a UBM preferably, if not, otherwise a B scan would provide you more information, when you are labeling a patient as aqueous misdirection. There was no doubt when we clinically look at your picture in the diagnosis and of course in the management, but as a resident, it's important that when you are asked about the investigations, because investigations are a part of management, so you must mention, and even if you are not able to do, you must mention that why you were not able to do. At least it just tells the examiner that you are aware as to what needs to be done.
Yes.
Yes, and instead of just cycloplegics, mention atropine because that's the drug of choice for this. But otherwise, very well managed and very well presented. Congratulations.
I request Hazari sir to ask questions to Dr. Tanvi.
Yeah. Hi, Tanvi.
Good evening, sir.
I have a simple question. Clinically, how did you diagnose that it was aqueous misdirection? You can give your answer in 1, 2, 3, 4, that these were the points which helped you
Sir.
make the diagnosis.
So one, I would like to say that there was increased intraocular pressure. Secondly, there was shallowing of the anterior chamber, which was present both centrally as well as peripherally. Third, with the patient had peripheral iridectomy, and fourth, the patient was pseudophakic. So all these four points towards the diagnosis of most probably aqueous misdirection, which I confirmed after adding atropine after giving the eye drop atropine to the patient, which caused deepening of the anterior chamber, and that way I clinically.
Okay, so it was a clinical impression which got confirmed by a therapeutic trial.
Yes.
Right? Now,
yes.
In your gonioscopy, you've written as angle closed.
That's
so, was the angle closed appositionally, or they were thick PAS all around 360 degrees closed? So, if you expect it to respond to just cycloplegic after so many attacks of supposedly aqueous misdirection, then would you really expect it to respond to just a little bit of cycloplegia with atropine for a few days? And was any gonioscopy done subsequently to document whether the angle has opened? It's just deepened, but that doesn't mean that the PA has broken. So how would you label it as chronic? Can't it be chronic aqueous misdirection syndrome, which happened a long time ago, and now the angle's just zipped up because of PAS? In that case, it wouldn't respond to only cycloplegia. So you need to have a confirmatory finding which will clinch your diagnosis rather than just base it on a therapeutic trial. So was any gonioscopy done later on?
We started with on atropine and we measured the pressure. It was 26 and 10. And actually, we should have. No, sir, it was not.
Tanvi, do you do gonioscopy yourself as a
Yes,
JR?
yes, sir. Yes, ma'am. I do gonioscopy myself.
Okay, so there is a history of YAG capsulotomy also in this patient. So the
Yes.
hyaloid phase anyway would have been disturbed by the YAG cap itself.
Yes.
Why do you think that this patient developed aqueous misdirection despite pseudophakia? Because it's not that immediately after this cataract surgery, the patient developed aqueous misdirection. So it was quite a few years after that. And the patient had additionally undergone a YAG capsulotomy. So what do you think would have led to development of aqueous misdirection?
Hypotonia can also cause.
But there is no support of hypotony. Are there any medications which push certain set of patients towards developing aqueous misdirection? So long-term carbonic anhydrase inhibitors and long-term myotics, either of these. And if the patient is a diabetic, then the chances of a late onset aqueous misdirection become likely.
Hazari sir, she has mentioned the patient has the optic atrophy in both, glaucomatous optic atrophy in both the eyes. Would you like to ask her some questions regarding that from the exam point of view?
Yeah. So was any visual field analysis done later on?
Yes, yes, sir. One visual field analysis was done in the left.
It was the 24-2, right?
Yes, sir.
And
it
with
was
such advanced glaucomatous damage in the disc and near total field loss, if you look at the 24-2, how would you follow it up? What additional perimetry tests would you do?
10-2, sir.
So why wasn't it done?
Sir, it was done, but I don't have the picture. I've not put the picture on the slide, but it was done, and I confirmed with the
What was your finding on the 10-2?
was complete tubular vision, sir, in 10-2 also.
So when you're talking about 10-2 and such advanced damage, would you describe it as tubular vision, or would you be more specific so that it gives a prognostic value? Like, for example, you talk about thread to fixation, split fixation, because then that would indicate how aggressively you want to treat it. So do you have any idea about whether there was any threat to the fixation in this patient? Looking at the optic disc, how would you predict the field to be, the 10-2? Can you show the optic disc pictures? Yeah. Can you expand on that?
Can you make it slideshow?
Yes.
Right. Now, how do you describe the left optic disc?
Left optic discs. Sir, the disc margins are distinctly circular. The cup to disc ratio is 0.9:1. There is a superiorly, there is a notch which is present, and the optic disc is scale. It is corresponding towards the glaucomatous optic atrophy.
So if there is a notch at the superior rim in an advanced glaucoma like this, if it's 0.85, 0.9, even though you see some amount of rim in this patient, but let's assume that there is a superior optic rim loss.
Yes, sir.
Okay, how would you expect the 10-2 field to be?
It will show inferior inferior scotoma. So if there
And
is a
is it,
superior loss, then there will be inferior arcuate scotoma. It can be presented as inferior arcuate scotoma.
and is it going to be close to the
Superior rim loss with the superior
fixation?
macula.
Is it going to be close to the fixation? Or is it going to be far away from the fixation point? I mean, is it going to be paracentral or it's going to be arcuate scotoma in the periphery? So you said it's a tubular vision, right? So you're
Yes,
already
sir.
talking about paracentral field.
Yes.
And if you're looking at this disc, from the disc, it doesn't look as if it's going to be that small, that tube of a vision. But let's
Yes.
assume that the superior rim is lost.
Hmm.
Then you would expect a inferior paracentral scotoma, which is impinging on the fixation. So there would be either thread to fixation or a split fixation inferiorly. Right. So even if you don't have those reports with you, if
Yes, sir.
you look at the optic disc pictures a little bit more analytically, you would be in a position to predict what kind of field you can expect in these patients, and that may score you some brownie points in your exam.
Yes.
Parul ma'am, would you like to ask us something regarding the RNA field defects or
Yeah.
filters?
So,
Can you
Tanvi,
please stop screen sharing, Tanvi?
Yes, ma'am.
so Tanvi, whenever we describe an optic disc or fundus per se, we always talk of media clarity, irrespective of whichever branch you are talking about. In relation to the optic disc, we must always mention the size of the disc because that makes a difference. Then the margin is well defined. You don't say circular, you talk about definition, whether it's well defined. And you talk about the isn't ratio, whether it is maintained or disturbed. Now here, looking at both the discs, it looks like concentric cupping where both the discs are equally thinned out on all the four quadrants. So it's more of a concentric cupping rather than just a focal notching. So coming to this, now when there is such an immense loss of the neuroretinal rim, then how would you see the change in the retinal nerve fiber layer? So first of all, how do you analyze the retinal nerve fiber layer?
CT. OCT RNFL.
No, clinically better.
Please stop screen sharing.
So even if you are not using the green filter on a fundus camera, you can still do that clinically, even with the basic tools. So can you name one?
Now, using a 90D is no.
But if you're doing a slit lamp with 90D, what filter are you going to use on the slit lamp? You're going to use a special filter to be able to make out the retinal nerve fiber layer defects or the retinal nerve fiber layer striations for that matter. So which color filter will you use? I've already mentioned it. We need a red-free filter.
Red-free filter.
Yes. So you can even use that on a direct ophthalmoscope. You have that. And even when you're seeing a direct ophthalmoscopic picture, then also you can make out the retinal nerve fiber layer defects. Although that's not the correct tool for ascertaining an optic nerve head for glaucoma. So why should we not use a direct ophthalmoscopic examination for an optic nerve head?
So the magnification.
Something else? You need to have a depth perception to be able to make out whether the cup is shallow or deep. And that you will not be able to do on a DO. So describing your disc in terms of shape, size, the isn't rule, and the retinal fiber layer defects, that's very, very important. And you mentioned that even 10-2 had a very advanced defect. So how will you step further in terms of visual field examination? If your 10-2 is also bad, now which is the next option that you have? You can do a macula test, which looks at the central 5 degrees. Why would you not like to do an OCT for this patient? Not.
So he would show faults. Was
There-
it a fault?
There is quite a lot of damage. The
Yes.
retinal fiber layer is
Fiber
thin.
layers will, yes.
So what is floor effect?
Will have a false,
No, not false.
false thinning. It will not show thinning. It will have a proper.
No,
thick-
no. Floor effect means that the retinal nerve fiber layer has thinned out so much that it has reached the rock bottom. So the thickness that the OCT will give you would be that thinned out retinal nerve fiber layer and the blood vessels. So there is nothing more to lose and there is nothing more to ascertain. So in an advanced effect, you either get a 10-2 done or a macula test if even 10-2 gets bad. But there is no point of doing an OCT when it has reached a floor effect. So it's very important to know that which other investigations you are going to order as the disease progresses.
So there was good discussion on this case, and I think now it's time to move to the next case. So next case will be presented by Dr. Hashnoti. She is JR3 at Government Medical College, Gondia, and her mentor is Dr. Praveen Dupare. And I'm very proud to say that he is a student of Government Medical College, Chhatrapati Sambhajinagar. So over to you, Hashnoti, and please start sharing your screen.
Yes, ma'am. Good evening, everyone. I'll be starting my case presentation. A patient, 41-year-old male, resident of Gondia, teacher by occupation, came to GMC Gondia Ophthalm OPD with chief complaints of stress on reading in both eyes since 1 month. Patient was all right 1 month back, then he started complaining of stress on reading in both eyes, which was gradual onset and non-progressive. It is associated with eyebrow ache and frontal headache and is aggravated by prolonged near work. Patient has symptoms relieved on sleeping and taking tablet paracetamol. Patient has history of multiple such episodes twice to thrice a week. He has no visual complaints for distance, no history of spectacle use, no history of nausea, vomiting, no history of watering discharge, redness, pain, photophobia, no history of colored halos, no history of trauma to either eye, and no history of any over-the-counter use of medication. He has no previous ocular illness or surgical history and any systemic comorbidities, has normal bowel and bladder movement, normal diet and sleeping pattern, no history of addiction. Family history, there's no unexplained blindness in family. Vitals were within normal limit and on systemic examination was uneventful. I'll proceed with ocular examination. Head posture was normal, facial symmetry was well maintained. Patient was orthophoric on Hirschberg corneal reflex test, and ocular movements were full and free in all directions. Uncorrected visual acuity in both eyes is 6.6 parts for distance and N10 for near vision, which is improving to 6.6 in right eye with plus 0.25 diopter cylinder at 20 degree and plus 0.50 diopter cylinder at 120 degree. Patient near vision is improving to N6 with add of plus 1 diopter spherical in both eyes. There's cloudy discharge on pressing over the iris, which is suggestive of mild meibomitis, and conjunctiva was normal with no congestion. Both eye cornea was clear. Anterior chamber is shallow with Van Herring grade 0 and optically clear. Iris of both eye has normal color pattern. Pupil in right eye, single central circular, 3 millimeter in diameter, reacting briskly to light, well-sustained reaction and consensual reaction was present. In left eye, it is central circular, single central circular, 4 millimeter in diameter, reacting with a ill-sustained reaction and consensual reaction was present. On swinging torchlight examination, relative afferent pupillary defect grade 1 was found. Both eye lens was transparent. Intraocular pressure taken with Goldman applanation tonometer at 1 p.m. in right eye is 22 mm of mercury and in left eye it is 48 mm of mercury. On gonioscopy examination with 4-mirror gonio lens, right eye shows occludable angles in 360 degree and on indentation up till posterior trabecular meshwork is seen in 3 quadrants with broad peripheral anterior synecdoche in superior quadrant with blotchy pigments in all quadrants. And in left eye also, angles were occludable in 360 degree with on indentation up till posterior trabecular meshwork is seen in 2 quadrants. And in superior quadrant, broad peripheral anterior synecdoche was seen. And in nasal quadrant, no angle structures were appreciated. Regurgitation on pressure of the lacrimal sac area was negative in both eyes. Undilated fundus examination with 90D was done. Right eye has a medium size, slightly oval disc with clear margins having vertical cup disc ratio of 0.5:1 with healthy neuroretinal rim. And left eye has medium size, slightly oval disc with clear disc margins having vertically oval cup disc ratio of 0.6:1 with mild diffuse disc pallor. Blood vessels and macula were within normal limit. And in both, so my probable diagnosis here is both as simple hypermetropic astigmatism with presbyopia and mild myomitis with right eye primary angle closure and left eye suspected primary angle closure glaucoma. Further, we have managed this patient. We have advised hot fomentation and eye massage for myomitis. Injection mannitol 20%, 160 ml intravenous given over 20 minutes start. Tablet acetazolamide 250 milligram. 2 tablets were given start followed by TDS dosing for 5 days and syrup potassium chloride 5 ml BD diluted in half glass of water. In both eyes, eye drop pilocarpine 2% in QID and eye drop combination eye drop brimonidine 0.15% plus timolol 0.5% in BD dosing. And left eye drop dorzolamide 2% in TDS dosing. Patient was referred for both eye YAG-PI under guarded visual prognosis. So he underwent YAG-PI and came back for follow-up after 1 week and is using medication, tablet acetazolamide 250 mg BD for 3 days, which he has stopped since 4 days, and syrup potassium chloride 5 ml BD, which he has stopped for 4 days. And in both eye, he is using eye drop difluprednate 0.05% QID and eye drop brimonidine and combination eye drop brimonidine timolol BD. I'll be presenting the significant findings post status post YAG-PI examination. So on anterior chamber examination, this anterior chamber has deepened with Van Herrick grade 2 and faint flare of +1 with some pigments in anterior chamber was found. And iris has patent peripheral iridotomy at 9 o'clock. Intraocular pressure with GAT at 10:30 a.m. shows both as 16 millimeters of mercury and patient was on eye drop brimonidine 0.15% with timolol 0.5% in BD dosing. On gonioscopic examination with 4-mirror lens, in right eye up till 3 quadrant posterior trabecular meshwork is seen and in superior quadrant there is broad peripheral anterior synecdoche still present and in left eye up till posterior trabecular meshwork is seen in 2 quadrants and in superior and nasal quadrant broad peripheral anterior synecdoche is seen. So on dilated fundus examination, red glow was seen, medias are clear. In right eye, medium size, slightly oval disc with clear disc margins having vertically oval cup disc ratio of 0.5:1 with healthy neuroretinal rim and no evidence of retinal nerve fiber layer defect on red-free filter. And in left eye, medium size, slightly oval disc with clear disc margins having vertically oval cup disc ratio of 0.7:1 with diffuse disc and NRR pallor and has slit retinal nerve fiber layer defect superinasally at 1 o'clock, not reaching the disc. This is the diagram. So in right eye, we can see here that slightly oval disc with cup disc ratio of 0.5:1 and here it is 0.7:1 and this is the RNFL defect at 1 o'clock hour which is not reaching the disc and here the rim is pale as compared to the right eye. Blood vessel, macula and periphery were within normal limit. So we have advised patient pachymetry, for ultrasound pachymetry for central corneal thickness, which was within normal limit in both eyes, and perimetry HVF 24-2 and 10-2 was advised. So this is a single field analysis of right eye using central 24-2 threshold with CETA standard strategy. This reliability parameters are within normal limit. Foveal threshold is 37 diopter. And on the gray scale, we can see some depressed points in the nasal step area, which is confirmed in the total deviation and pattern deviation plot. And glaucoma hemifield test is borderline, and pattern standard deviation is with p-value less than 5%. And this is a single field analysis printout of left eye with using central 24-2 with CETA standard strategy. Reliability parameters are within normal limit. Foveal threshold is 36 decibel. Here we on grayscale we can see some depressed points in superior hemifield area, and total deviation and pattern deviation plot shows superior arcuate depressed points in superior arcuate area more than the inferior arcuate area. Glaucoma hemifield test is outside normal limit, and pattern standard deviation is mean deviation and PSG both p values are less than 0.5%. Then this is the OCT, optic nerve head and retinal nerve fiber layer analysis. Here we can see that in the right eye there is no RNFL thinning, and Disnet graph is also under the green area. And in left eye, inferior and superotemporal quadrant mostly the RNFL thinning was seen. So my diagnosis here is simple. Both are simple hypermetropic astigmatism with presbyopia and mild myomitis with right eye primary angle closure, status post patent PI, and left eye primary angle closure glaucoma, status post patent PI. Patient was advised eye drop difluprednate 0.05% QID for 7 more days, and eye drop brimonidine 0.15% plus timolol 0.5% in BD dosing in both eye, and in left eye, eye drop dorzolamide 2% in TDS dosing was added. Thank you.
So before Madam or anybody else asks you any question, Dr. Ashnathi, my simple question is, are you a resident or are you a glaucoma fellow? Very, very well presented. And back to Archana.
Thank you, sir. So because of my mentors have guided so well,
She's
that
the first PG student resident of their college. So I'll go to Hazari sir first. Will you please stop screen share? Yeah. I'll go to Hazari sir first, and I'll request him to ask her questions.
Difficult to ask questions with such a good presentation. Very thorough, very thorough.
Thank you, sir.
Yeah, let me think, what should I ask? On the gonioscopy, you've written occludable angles.
Yes, sir.
And open till PTM.
Yes, sir.
So how do you describe, when do you call an angle occludable angle?
The angle is, we will call angle is occludable when we cannot see the posterior trabecular up till posterior trabecular meshwork in either 180 or more than 180-degree quadrants. So then it is called occludable.
So would you like to revise your statement that they were occludable angles?
So yes, so because we cannot see the posterior trabecular meshwork in all quadrants in right eye, in both eye actually, and on indentation we could see posterior trabecular meshwork in right eye, and in left eye broad peripheral anterior synecdoche up till 180 quadrant was seen in nasal and superior part.
So can you tell us the difference between PAC, PACS, and PACG on gonioscopy?
Yes, sir. So if according to International Classification of Geographical and Epidemiological Society, it is said primary angle closure suspect if if the patient has more than 180 equal or more than 180-degree of iridotrabecular contact on gonioscopy, but intraocular pressure will be normal, optic nerve and visual fields will be normal, and it will be called primary angle closure if patient has more than 180 or equal to 180-degree of iridotrabecular contact on gonioscopy with either raised or normal intraocular pressure and other signs of iridotrabecular contact like peripheral anterior synecdoche, pigments in the trabecular meshwork, or iris atrophy, iris whirling, glaucom flecken. And primary angle closure glaucoma is this all findings with the optic disc and visual field changes.
So, do you think that only an iridotomy would help in this patient? And how would you like to follow up on this patient over the next 3-4 years?
Some studies have shown that the iridotomy, peripheral iridotomy, is mostly after 2 years in cases of primary angle closure glaucoma. The patient may need further medical and mostly added surgical therapy. So I will follow up this patient and I will decide the intraocular pressure and will follow up with visual field printouts and optic nerve changes. And if it is progressing, then we can look for other options. Since this patient doesn't have cataract, then we can think of clear lens extraction in this patient.
Okay.
If not, if the disease is progressing, then.
Okay. So how often would you like to follow up this patient? In this immediate post YAG-PI setting, how often would you like to follow this patient?
In YAG-PI, we follow up the next day, then after a week, and we should follow then after every 2 weeks, then so monthly, and then we can follow this patient 3 monthly with that.
Okay. So the point is that you need to be very careful in these
Yes.
patients and have close monitoring, because it's a very high pressure glaucoma that has suddenly settled down with just a YAG-PI, and you already have a broad-based PAS in one quadrant, and the rest of the angle is opening only up to PTM, even after YAG-PI. So one would expect a very turbulent IOP trend in the near future also.
Yes.
Right? And the other thing that I was a little taken aback was your use of difluprednate after a simple YAG-PI. Amongst all the topical steroids that are available to you, which is the steroid which is most likely going to cause steroid-induced glaucoma, a raised IOP due to steroid? What do you think?
So I feel dexamethasone and prednisolone, these are the hard steroids, are related to raised IOP. And so like FML and softer steroids are less associated with raised IOP. In this patient, difluprednate is continued because of the anterior chamber mild flare is there, and pigments in EC were present. So we have prolonged the steroid for a week.
So as far as my limited knowledge on uveitis goes, difluprednate is about 6 times more potent than prednisolone acetate. And if you use difluprednate for 4 times a day for more than 2 weeks, 3 weeks, it's very, very likely that the patient is going to have a steroid-related response to IOP. So that's going to confound your IOP rise. If you notice it in the future after a month or so, is going to be confounded by the use of such a strong steroid in this patient.
Yes,
so little bit of inflammation in an acute angle closure glaucoma is expected. Yeah, okay, you use prednisolone acetate or maybe fluorometholone for some time, and bring down that inflammation. But once the YAG-PI is done, you don't expect too much inflammation due to the YAG-PI. And a simple fluoromethalone for a couple of weeks usually settles down the inflammation. You can also add some NSAID, simple NSAID like a paracetamol, something like that. So using difluprednate in this setting may not be such a good idea.
Yes, sir. I'll note that.
Parul ma'am, would you like to ask her regarding some anti-glaucoma medications and the surgical treatment of glaucoma as well?
Sure. First of all, very, very impressive presentation. And so far you have responded to all the questions also even more impressively. So congratulations.
Thank you.
Before I ask you any question, I just had one suggestion to make. When you write a gonioscopy finding, which is indentation finding, so when I look at what you have presented, to me, it will look like an open angle because you have written PTM in 3 quadrants.
Yes,
So we
ma'am.
always write the finding that is there first, followed by an arrow, and then what it opens up to on indentation. So for example, if I see without indentation an ATM, I write ATM, then I put an arrow, then I write a PTM, suggestive of the fact that pre-indentation it was ATM and then it became open up to PTM. So that's one suggestion I wanted to make. And when you say the grading is based, the occludable grading is based on the pre-indentation status. So here, when you have justified that it's an appositional angle closure, it would be because of the pre-indentation status. So that's something that you have to keep in mind. I want to ask you, what would be the iris findings that you would like to see in such a patient first, before we go on to the medication part of it?
I would like to see for any pupillary rough atrophy at the margins. This is a good finding for screening the patients for angle closure suspect. Then any sectoral iris atrophy or iris whirling, the pattern, radial iris pattern will be lost. Or
Patchy iris atrophy. And so you must see under a high magnification for all these iris findings. Amazing. Was the visual field that you showed the first visual field?
should I show
No,
again?
I don't want to see. Was it the first visual field that the patient had done?
Yes, ma'am.
So there would be an element of learning curve. So we always get 2 reproducible visual fields done to be sure that the defect that is coming is actually because of the disease. So that's one thing that I wanted to highlight. So having said that, I completely agree with Dr. Ajit as regards difluprednate, and that's the point that I also wanted to make. It's notorious for causing a steroid response, and in my practice, after having burnt my fingers once, I have never used this drug. So just a pearl from our own experience that it's better to avoid it. Having said that, what do you know about the EAGLE study?
Ma'am, EAGLE study is the study for early lens extraction for preventing primary angle closure glaucoma in cases of primary angle closure or early primary angle closure glaucoma cases. In this, the patients more than 50 years old with no cataract changes or were included, and who has either primary angle closure or early primary angle closure glaucoma, and excluded patients were with symptomatic cataract and the ones who have severe advanced glaucomatous changes. So this study has shown that doing this study has compared the laser peripheral iridotomy with early lens cataract extraction. So it has showed that there is a difference of lowering in intraocular pressure by 1.18 millimeter of mercury in cases in which clear lens extraction was done, and it has also shown to be cost effective and has reduced the further medical and surgical need in these patients. So according to this study, the primary option for primary angle closure and PACG should be early lens extraction.
So are you aware of the limitations of this particular trial? And that's why I asked you the question, because this trial shot up in fame because of the cataract surgery suggestion. But once everybody analyzed the data, they found a lot of limitations. So are you aware of that? If you're not, then you must read those, because that's one of the questions that can be asked. Secondly, in which patients would you like to consider an iridoplasty?
Ma'am, if after even the patent peripheral iridotomy, the angles are not deepening and the same occludable angles are there, then we should think of in the lines of plateau iris syndrome. And in that patients who have thicker iris, so we should do iridoplasty, could be done in that patients.
How will you recognize a plateau iris?
Ma'am, on gonioscopy, there's a double hump sign. The first hump is due to the lens vault, and the second one is due to the anterior move position of the ciliary body. So that is.
So the sine wave sign or the test of choice is the UBM, so you will see that. What
Yes.
should be the location of an iridotomy to address the plateau iris?
Ma'am, since I've read that the chances of superior angle getting occluded is more because of the anterior position of ciliary processes in superior angle. So I think that 12 the superior part
Now,
would be.
no, what I wanted to say was that many a times it's done mid-peripherally. So it should be extremely peripheral, the iridotomy, so that the aqueous can push the anteriorly rotated ciliary process back.
Yes.
You have done amazingly, and I am super proud of, how thorough you have been. So hats off to you.
Thank you, ma'am.
Very well answered, Ashwati.
Thank you,
All
sir.
very well read and very well answered.
Thank you, sir.
Hazari sir, would you like to ask her anything more?
No, I think we'll give her a break now.
Okay, so really, Harshnath, it was a good presentation, and congratulations to Praveen as well, because he's a mentor, and really very proud of you both.
Thank you, ma'am. We have tried to take the legacy of GMC Aurangabad and Sambhajinagar ahead, and my teachers' guidance. And also, we have one glaucoma fellow here in the department. He also keeps on teaching our residents. That also helps a lot. Subspecialty teachers available in the department helps.
It's a new college, actually. GMC Gondia is a new college, and she is the first batch of residents they have. So, Dr. Piyush, would you like to make any comments? Your concluding remarks?
Don't see the president there, but I mean, I'm just spellbound. This is probably one of the best case presentations that I had seen. So many congratulations for that, Dr. Harshnath and Dr. Praveen.
Thank you, sir.
Excellent presentation by Dr. Tanvi and her mentor, Dr. Preeti as well. But most of all, thank you very much, Dr. Parul and Dr. Hazari sir. So, I mean, the questions that you answered and the kindness with which you all taught us the MOS students was absolutely phenomenal, and we wish you that we would want to have you again in our subsequent webinars also, so that more and more students can learn apart from ophthalmologists like us. It's a revision for us as well. So thank you very much from the bottom of our hearts for sparing the time.
Yes, thank you, Hazari sir, thank you, Parul ma'am, and wish you all a very, very happy Holi.
Yes, happy Holi to everybody. Thank you.
Happy Holi to everyone.
Thank you. So, should we leave the meeting now?
Yes, thank you, Dr.